الرحمن الرحيم. السلام عليكم. طيب نزار دائما السبب. أول حاجة خلاني آخر واحدة في الكونفرنس، وثاني حاجة he forced me to put cases from Africa, so I cannot say no to the boss يعني. طيب we'll start quickly. I promise I will not keep you for a long time. The first case. He's a 26-year-old male patient, and he's MSM, diagnosed with HIV 1.5 years ago, and started on efavirenz and Truvada. He used to be adherent. He's a very well-educated man. He spoke 3 languages, Arabic, English, French, and a bit of German. His latest, or CD4, at the last visit to the clinic was 480, and viral load was undetected. And he presented to our emergency with a 10-hour history of abnormal behavior and depression. Any thoughts, any questions? No, you force me, no way. And yeah, he's هو نزار السبب. Anyway, so he presents with acute onset abnormal behavior, depression. Actually, he was hallucinating. He was shouting, crying. He refused to talk, suddenly jumping. So he's really in abnormal behavior. Any questions? 480, last visit to the clinic, which was like 1 month back to his presentation. I can't hear you. He's afebrile. Review system was negative, and he has a lot of social problem at home, and he brought to the emergency with his partner. No seizure? No history of drug abuse, no history of cocaine, hashish, nothing. Should we proceed? On examination, he's a young gentleman. He was afebrile. He's maintaining vital signs within normal, but he was very anxious, irritated, agitated, hallucinating with some visual hallucination. But in between, he was fully conscious and oriented to time, place, and person. His examination, chest, cardiovascular, abdomen, even CNS was normal, apart from on and off the abnormal behavior. And his reflexes only was exaggerated. So, any thoughts? So you want to do CT brain? Okay, CT brain was normal. No history of contact with animals, no.
This started from what?
10 hours. Sorry?
Is it related to efavirenz?
He's been on efavirenz and Truvada for 1.5 years. LP? LP was normal. No trouble history. I can't hear you, doctor. No new medication at all. Nothing changed in his life apart from his social problems. He's not alcoholic, no. Contrast. CT with contrast, normal. So CBC, chemistry, LFT, urea, creatinine, CT brain with contrast, it's completely normal. Anything else? LP was negative. Nothing, crystal clear. Apart from, of course, we don't have PCR from CSF, so otherwise WBC, chemistry, gram stain, latex, anything, it's negative. Sorry? He went once to psychiatrics when initially diagnosed because of the social issues. And then he didn't like to continue, but he didn't start him on any medication. Actually, the psychiatrist was willing to sit with him like a few sessions, and then he will decide. But he shows once, and then he disappears from the psychiatric clinic. So you think after 1.5 years, he will have side effects from... Okay, so what we did, we admit the patient. We keep monitoring him with the CBC, LFT, renal profile. For almost like the first 6 hours, he was in the same situation. He's not improving even, like sometimes they give him the physician, the on-call, like they start him on Valium, just PRN to calm him down a bit. But after like 3 to 4 hours, his partner came and told us that he found his medication bottles empty at home, efavirenz and Truvada. Actually, he presented to us the last time to the clinic 1 month back. And he has another supply at home so he has at home 1.5 bottles from each, efavirenz and Truvada. He brought 2 bottles empty. One is efavirenz and the other Truvada. So we thought that he suffering from overdose. What should we do? Anyone of my colleague facing efavirenz overdose, Truvada overdose? What should we do?
Definitely stop use of any drugs and give supportive therapy to treat acute psychosis. You're asking if there's any antidote.
Yeah. Any rule of, for example, of gastric wash, charcoal? So he came after 10 hours, so it's too late. Any rule of antidote for efavirenz anyone knows? Okay. So actually we reviewed the literature for this patient, and what we couldn't find actually anything new about the efavirenz overdose or Truvada overdose. It's only general supportive measure, and charcoal only have a role if it's within the first 2 or 3 hours. And there's no specific antidote for antiretroviral, and it's highly protein bound, specifically like efavirenz, and dialysis also is unlikely to remove the drug from the blood. This is regarding the efavirenz. Regarding the Truvada, if overdose occur, the patient must be monitored also for any evidence of toxicity, especially the renal profile, acidosis, and also it's the same like efavirenz, limited data about the overdose. And what I could find that there was a trial, like single dose of imitricitabine, 1,200 milligram, were given to 11 subjects, but there was no severe adverse reaction were reported. And hemodialysis treated patient remove like only 30% of imitricitabine, while tenofovir, imitricitabine and tenofovir are the constituent of Truvada. So tenofovir, they found that it's efficiently removed by hemodialysis if the patient developed renal failure as a complication of the overdose. So patient admitted under observation. After like 48 hours, nothing changed in his liver or renal profile. And the surprise, his family came to visit him, like his mother and father, and he admit that he read the pamphlet of the efavirenz and he act because just to attract his family attention. What I found also that there was a case of voluntary intoxication from efavirenz and lamivudine, and it was published on AIDS Journal in 2006. And there was a lady, a 17-year-old lady, that she took overdose of efavirenz. It was a suicidal attempt. And the presentation was also it's a mix of neurological and psychiatric manifestation. And then the effects resolved like from 3 to 5 days, and she was discharged home. This is the first case. I promise will not keep you long. The second one, 46-year-old gentleman, newly diagnosed as HIV. His CD4 on presentation was 40 and viral load 2.5 million. He presented with seborrheic dermatitis on the face and multiple skin lesions. The skin lesion was like papular, pustular, and it was on the face, trunk, upper limbs, and on the back of the scalp. He's not known to have any chronic medical problem, and he's not on any medication. I hope. Actually, here, maybe it's not very clear, but small papule there on the back of the scalp. And this is another one. You have a pointer? Yes. Yeah. This is the other one.
Where is this?
This one on the back. This one is here, and this one. Some of them are pustule here. And this was on the, this also on the back. Small pustule. So, any thoughts? No, not known to have any medical problem. He's not diabetic, not hypertensive. It was actually very itchy. Sorry? Okay. Any other thought? Okay.
Measles. Chickenpox.
Chickenpox can be differential, but measles, no. No, I'm asking.
Do you know about this lady status?
Sorry?
You have chickenpox?
Yes, he has chickenpox before. So, any other question, or we'll proceed? No, no contact with person in the family having the same problem. No, it's on the upper arm, in the chest, and in the back. Okay, so his baseline investigation, his WBC was 2.7, neutrophil 0.8, eosinophil 0.04, and his hemoglobin 13, platelet 200, chemistry, other investigation completely normal, and this is the skin biopsy. Actually, I don't have the real picture of the skin biopsy for the patient, but this is the similar picture to his skin biopsy. So anyone? Actually, there is a lot of infiltration with eosinophils in the biopsy, and the diagnosis was eosinophilic folliculitis, which is a pruritic skin eruption that commonly found in patients with HIV, and the incidence is around like 9%, specifically in HIV patient with CD4 less than 250, and the mean CD4 was around 60 to 64. The etiology, it's not known, but there are theories that some of them could be due to mites, some due to bacteria, some due to yeast, but till now it's not proven. It could be an inflammatory disease related to immune dysregulation and perhaps in association with an underlying infection. The differential usually of this lesion, it's acne or bacterial folliculitis, Steroid could induce this kind of rash, drug eruption, scabies also. And as we said, the diagnosis depends on the clinical suspicious and the appropriate presentation, plus the histological finding. Any idea about the treatment? Steroid. Anything else? So, topical steroid can play a role. Indomethacin, it's not working with eosinophilic folliculitis. Itraconazole can play a role, but not because of its antifungal activity, because as an anti-inflammatory also. And retinoids actually have a very good role in treating eosinophilic folliculitis. But at the end, antiretroviral therapy, it's very important in controlling the presence or absence of those infection. And but the problem with antiretroviral, it will take time, and up to 3 months in resolution of those skin lesions. Actually, what our dermatologist did, that they treat the patient with Roaccutane. And they found really that it's working very well, and the resolution of the infection, or sorry, the resolution of the skin manifestation appear rapidly, like within 2 to 4 weeks. He is an antihistamine, but yeah, but it's not really helpful. Maybe it will help in itching, but it's not helping in resolution of the skin manifestation.
What was the rationale?
I think it's vitamin E. It can actually, retinoids play a role in treatment of eosinophilic folliculitis. So they give the patient, or start him on Roaccutane, and they give him like high dose intensive course, and then they found that the patient really respond. I will show you a picture of the post-treatment. This is one of the patient and with lesion in the upper limb, and this is the other one on the back. Okay. The third case actually, I will not say anything. I will put it for you now, and I will wait for your answers after finishing. I hope it will work. ما في صوت. So help me to solve this issue, please. Actually, I cannot solve it myself, and I cannot solve it alone. I cannot solve it with Jam'iyya alone. Without you, we cannot solve this issue. Thank you.